All right. Hello, everybody. Good afternoon. It's so good to see everyone. I will give you all a moment to get connected. So glad to see everyone joining us today for our last in our four-part series with Kiowa Kieran on the art and practice of planning. And today we're going to be focusing on preparing for a medical appointment and how to organize all of those things that you need to be prepared for these medical appointments. So before we get started, I'm Anissa Mitchell, and I am going to be speaking with you today along with Meredith Hatcher. She is a physician assistant with the Texas Movement Disorder Specialist in Georgetown, Texas. Hi, Meredith.
Hi, hey everybody.
So as we get started, this is a very interactive program today. I want you to go ahead and open up your chat box so that you can give us a shout out. Let us know where you're joining us from. As we go through the program today, we are going to take your questions all throughout the program. We're not waiting until the end. We're taking them from the very beginning all the way through. We also will give you the opportunity, if you wish, to unmute yourself and ask a question. The only thing that we ask is that you notify us through utilizing your reactions. So you can wave your hand that you want to ask a question, just so that we know, because we have quite a few people. We can't see everyone. So if you would just notify us that you want to do that, we want to hear from you. Now, if you pre-registered before today, you should have received an email. And in that email, you received a handout just like you did before. And you should have received actually a couple of things. One looks like this. And this is in regards to creating a personal health record. We'll reference that later. And also you should have received our Empowered tool and our Snapshot tool, which again, we'll reference later. But these are some things that you can do as you are preparing in the future for your medical appointments and having informed conversations with your healthcare provider. So you know that we've been talking a bit about the survey that Kiowa Kieran did with Care Partners, which has framed a lot of the information that we've been discussing over these last 3 other episodes before this one. And it's really given us a lot of great information. And the survey conducted found that some of the biggest challenges people have, especially care partners, was understanding all of the symptoms that accompany the progression of the disease, all the comorbidities that impact them. And obviously they found that confidence was higher in that understanding when they had ongoing conversations with their healthcare provider. So that is something that we really want to discuss. How can you have, in a small amount of time, a really good conversation that's robust and really covers everything you need in those snapshots of time? So a lot of people kind of rely on their healthcare provider, whether it's their physician or the advanced practice provider, to be the ones to bring up things, but everyone is unique. Everyone has different symptoms, and the things that are most important to you or the most troublesome to you or your loved one is going to be varied by person to person. So we want to help you kind of find ways that work for you to have these communications with your doctor. So I want to start off first with a poll question. We actually are going to have 2 poll questions today. So if Kelly could pull up our first poll question, I want to get some feedback from all of you today in your terms of how confident you feel in your ability to discuss your symptoms and concern with your healthcare provider. And I'm going to give you a second to answer that. Okay. And yes, if you didn't get the handouts ahead of time, you will get a follow-up email, and they will be included in that follow-up email. So we'll make sure you get them. All right, so we're kind of neck and neck, a little bit more. People do feel pretty confident in their ability to discuss things with their physician and some somewhat. So good that nobody's feeling that they're not at all confident. So that's important. So maybe after we go through this discussion today with Meredith, you'll feel even more prepared. So I want to go back to introducing Meredith. She is actually a physician assistant, and she works in Texas, as we said. And Meredith, I wondered if you could start off explaining a little bit about the role of an advanced practice provider in movement disorders, how you as an APP can be a wonderful resource to people with Parkinson's and their care partners.
Yeah, thanks, Anissa. It's fun to see where everybody's from. Welcome from all over. I saw a couple from Texas, so maybe some familiar faces. But to start off, when we're saying an advanced practice provider or APP, that includes physician assistants and nurse practitioners. So we do similar things. We have additional training after college to be able to diagnose, order lab work, see patients on our own. We can prescribe medications. We work as a team with the physician in the office. We can see patients on our own, but if there's ever anything that we need to discuss with the physician, we work very closely with them. Generally, the most important thing to remember about us working in neurology, or specifically in movement disorder, is that this is all we do all day. We know Parkinson's because we don't work in any other specialty. So most of us have been doing this for several years and are very familiar with Parkinson's or other related movement disorders, and are very confident in treating it.
Fantastic. And you're such a wealth of knowledge, and you actually, is it true that you get a little extra time when
Yes.
you're seeing patients than maybe the movement disorder specialist?
Yes, a lot of the time we do. It's different depending on the clinics, but generally a movement disorder specialist may have a 6 to 8 month long wait list, whereas mine may be a month or two, and I generally have a longer amount of time with everyone. So we went to PA school or nurse practitioner school because we wanted more time with our patients, and that was, of course, physicians do too, but we are blessed that we are able to have a little bit more time like that.
Absolutely. And for those of you who are familiar with PMD Alliance's ecosystem in our medical network, advanced practice providers, PAs, and nurse practitioners are a very important part of that network. And so I know a lot of people, before it became a little more normal to see an advanced practice provider, were a little put off by that. They're like, well, you know, I want to see my doctor. And then once they get in and they benefit from that relationship, they realize that they do get a little more time, and they feel like their needs are addressed a lot more broadly than maybe they would have with their physician, just because they had that time. Mm-hmm. Meredith, can you talk a little bit about the importance of building rapport, not just with you as a PA, but just in general with a healthcare provider, in terms of this being a long-term disease, and it's something that you'll have ongoing communication and appointments with your physician. It's really important that you have a good relationship with that healthcare provider. Can you speak to that a little bit?
Absolutely. Yeah, you're exactly right. When we're treating Parkinson's, this is a chronic condition, and that's one of my favorite things about being in this specialty is we will get to know you over time and know your family and get to work with you. It is important to build that rapport, that we have a good working relationship, that we trust one another, that you feel confident bringing up concerns with us, and we can, of course, work as a team. We think of this more as we are just one member of the team. You have other physical therapists or speech therapists, home health, your primary care provider. We are just one member of the team between you and your family. And so it's important to remember that, trust us with your care and your concerns, and know that we are doing our absolute best to help in any way that we can, made easier by us getting to know you over time and knowing what your typical problems are and how we can help you.
So I know that it's important for care partners to join in the appointments with the person that's diagnosed. And sometimes early on, they may not bring their spouse, their partner, their adult child, or whomever is in their life for lots of different reasons. But can you talk about the importance of there being somebody at an appointment, even if they don't have a care partner, if someone's maybe flying solo and they don't have someone? Why is it so important for them to have that second set of ears and eyes?
Such a good point. And hi, Julie, I saw your message just now too. Yes, such a good point. A lot of the time early on, we do just have people that come by themselves. And I get that, because you're thinking, well, I'm doing okay right now. I don't need other people to come with me. But there can be so much information covered in one visit, even just education about Parkinson's in general, kind of understanding what things to look for or how your medication should be taken, your gut, your diet, your exercise, all kinds of things that your care partner or your family, if they understand those things, they can help as a part of your team as well. The other thing is, I don't know about y'all, but even me, when I go to my doctor's appointments, if there's a lot of information covered, I won't remember everything. So having two sets of ears is helpful, and even having someone who can help you take notes, I think is super important.
And someone just said, my daughter will often use iPhone to also be at the appointments if they're out of town. Have you done that in your practice? Have you had someone with you in person and then have somebody call in?
I've had that happen some. I will say sometimes it's a little bit tough if they're just on speakerphone, because I can't always hear them as easily, or they can't always hear me, and they may not be able to see what we're doing. Like if I'm watching you walk, they're not aware of what's going on. We have had more people, if we are doing a telehealth, a video visit, that's become more and more common with COVID these days. We have had some people join in the video visit calls, and we can join several people doing it that way.
And a person made a really good, they're just named iPhone, but they made a good point. You're assuming that the person with Parkinson's has a spouse, partner, or friend. So when you have someone who is in a situation where they don't have a lot of support, in terms of your experience, what have you seen with people coming into your practice?
Well, even if it's just you, that's okay. Of course, you are able to communicate any concerns you have as well, but make sure that maybe you're taking notes, you're still making a list of your concerns ahead of time. Even if it's just you that's able to go to the appointment, you may interact with some other people who have noticed some things. So that's perfectly okay, of course. This is just, it's important if you do have family that's greatly involved in your care. They may notice some things that you may not.
Well, and some of the things that we're going to be talking about later in this session will help you if you are someone who is single, flying solo, and don't have that support. And if you were in the first session where we were talking about planning for the future, we did kind of touch on the fact that there are circumstances where you may not have that support system. And later on, you might want somebody to join you in on your appointments, and that it might be helpful to hire an advocate, a care manager, an aging life care specialist is what they call themselves now, to partner with you and attend. That doesn't mean they're in everything, but just having that second set of ears and eyes to take notes while the doctor might be doing, or the PA might be doing assessment with you, and you're busy with doing, certain activities. They can be taking notes and just listening to what the healthcare provider is saying, so that you can get all of those details. Because like Meredith said, you might hear it and then you might forget it 5 minutes after walking outside of the door. And right, Jean is totally right. Online portals that they offer, we're going to talk about that too, are a way to get summaries of your reports. If in most practices now do offer those, correct, Meredith? Yeah. So another thing, and I think you referenced this earlier, but as you know, having a second set of eyes in there, if you are the care partner or you have a care partner, you know, sometimes they see symptoms that you don't see that really can benefit the healthcare provider in getting both perspectives. What has been your experience with that, Meredith?
It happens all the time. Yes, that there may be something that that your friend or your family, your spouse, they may notice that you are tremoring or you are having a little bit more trouble with your walking, where you may not always notice that. I think this is especially common with a lot of the non-motor issues, which I think we'll get into a little bit later, but happens all the time that the patient may not necessarily see it themselves as clearly.
Well, and even just yesterday, we had a talk on auth and dyskinesia, and the physician speaking at that point said that sometimes early on when people are dyskinetic, they don't even realize they're dyskinetic, but others can see it. So having someone who visually can see things that you yourself may not have insight into can really be helpful for the physician or the nurse practitioner PA to address. Okay, so one of the things I also wanted to ask you about is the types of things that you like people to bring to their appointments with them. So what kind of information do you need, and what do you often see is missing? Yeah,
this is great. The biggest thing is making a list ahead of time of the things that are bothering you the most. We have about, it depends on the office, of course, but with us, we have about 30 minutes for each appointment. You could spend all day talking about all the different things that can occur with Parkinson's. And we will, as we get to know you, as we build rapport over time, we will, of course, check in on the things that we know are problems for you. But if there are new things or things that you're wondering if could be related to Parkinson's, we won't know about it unless y'all bring it up. And so I think it's really helpful making a list ahead of time. We also at our office, we give everyone a handout at the beginning of the appointment where you can circle kind of the major motor or non-motor issues to help focus attention. The other thing I wanted to mention here is make sure you always bring an up-to-date medication list. This happened to me this morning, actually. I saw a patient that had no idea what they were taking and didn't know how they were doing with their medications. It's very difficult to adjust medications or help if we don't know exactly what you're taking, how, when. That's a crucial piece.
Absolutely. Back when I worked in the hospital and you know, we would have people coming in with big like grocery bags of their medications, and they would plop them down and we would go through this. You know, now we have so many tools, we don't necessarily need that. And I think it was in our last program, we did share one of many types of tools that are out there that are just a way to track your medications. But you know, it's important, and because you're not just seeing your movement disorders practitioner, you're also seeing a variety of other doctors, your primary care doctor, your cardiologist, your endocrinologist, your, you know, proctologist, whatever your ologist might be. They are all treating you from a different perspective, and they may be prescribing medications, and they may not know that you're on this from this doctor and that from that doctor. And so it's important for you to have everything that you're taking down, including supplements, right, Meredith? Because those can interact.
Yes, Absolutely. A good example of that is iron with carbidopa-levodopa can affect the absorption. If we don't know you're taking iron, then all of a sudden your medication's not working as well. So you can see how that may have an effect. So definitely a full list of all the prescribed medications, any supplements, that's always good to have. And then I just saw the question from Jessie too about what tools can you help to track changes and communicate them. I know, and Anissa, you have a tool for that too, but.
Yes, and I'm actually going to share it. So
Okay.
if you, and here in a minute, but if you got the handouts in the email, it's attached to that. It's just one form, but I'll talk through how we utilize that form. And then if you didn't get it, you will get it in the follow-up email, but you're going to see it here visually when I share the screen. But one of the things that I wanted to point out was that it's important to not just focus on, and you mentioned this, Meredith, but not just on the motor symptoms, but we want to know about all the different non-motor symptoms. And so I'm curious, I have another poll for you, last one, I promise, but I love just hearing from you, like how confident you feel in being able to recognize motor and non-motor symptoms enough to communicate these with your healthcare provider. So I'll give you a second to answer this poll question. And I'm seeing some good results that people are pretty confident. So I'm glad to hear that. A few people that are somewhat confident. And, you know, I think we can always improve. So give it a second more, make sure we capture everybody. Okay. All right, so we have about 59%-ish, 56, it keeps fluctuating, people who feel confident that they recognize enough of the symptoms, be able to communicate them, and then about 43%, somewhat, only 1%, not at all. So that's good. I'm glad to hear that. So. And that's really important. And I want to go back and just reference real quick that I love this idea that if a patient writes their medication down, you can assess their writing also. Mm-hmm. So that's a really good point. All right, so I'm going to share my screen. Bear with me. And I'm going to show you the tool that I was talking about. So this is our empowered tool. You probably have heard us talk about this before. It's available on our website. You're going to get it in an email if you didn't get it before. And it is long, I will tell you that, but it's not something that we expect anybody to fill out every time they see their doctor. This is actually intended to be a 4 times a year review. So quarterly review of your symptoms. And then we're going to show you what the snapshot tool is. So that would be used every time you go to your doctor. So this is actually a fillable PDF, but you can print it out. And what it does is ask you to go through, and you can see as I scroll through here, a ton of things. But we realize that sometimes we wonder, is this really a Parkinson's symptom? You might not know to tell the doctor or your PA or nurse practitioner something that's going on because you may not recognize it as a symptom of the disease. So this kind of helps to prompt you. And what we ask you to do is just write the date down that you're doing it. So today would be, August 18th. And then you're going to go through here and you will identify blank. This is not a problem for me. So you don't even need to do anything with it. Sometimes would be like an X, or you could do a check mark. And then an A would be identifying something that you always or very frequently have a problem with. And so you go through each symptom. And really it's pretty comprehensive. So you go through this, and I recommend, and Meredith, jump in anytime, but I recommend that the person with Parkinson's and their care partner do this together. Number one, another thing that I recall in the Kyowa Kiris survey was that it was an interesting finding, and it wasn't a large difference, but there was a slight difference between men communicating with their care partner versus women communicating with their care partner about symptoms. And I think when you are discussing it and you as the care partner identify something that the person with Parkinson's doesn't identify, it can be helpful in having that discussion and then bringing it to the doctor's attention or in Meredith's attention, like a PA. So just going to show this. And then when you're done completing this, then you complete the snapshot tool. And I'm just making sure this did switch over to that tool. You're seeing that? Okay.
Yes.
So this is obviously a one sheet. So it's a smaller tool, a lot less cumbersome, but you can show the doctor or your PA or your nurse practitioner, the bigger tool if you want, but this encapsulates all of it. So now you can just say, these are the 3 things that have gotten worse since my last appointment. These are the things that have gotten better. And this is a symptom I would like to change, or complications that's seriously impacting my well-being. And then something you should also know, or a significant question that you have. Knowing that you have a limited time, this helps you to be organized in that conversation, utilizing that larger tool to kind of help you get to that point. So, and I see Kelly added a link for those also in there. So
yeah, I love the way that's organized, because there of course there will be things that change each time, but it's nice to see also things that have gotten better, because with almost every visit, we're trying to improve upon several things. So yes, there will always be things we can work on, but it's also nice to see things that have gotten better too. So I like the way it's organized. And the thing that I think is always helpful for us too is having the couple points you want to talk about, but then there's that one thing that if I could fix this thing, I would be doing much better. Because then we can really focus in on that issue and try to tackle it. The only other point I wanted to make too is, because telehealth and video visits are so common these days, treat those like a normal visit. I can't tell you how often we do video visits and people think of them more like a phone call, like a very quick, yeah, things are doing okay, I need a medicine refill, okay, I'll see you in 6 months. Well, then 6 months goes by, and the next time we see them, there's a whole bunch more things we need to talk about that really started back then, but they were waiting until they saw us in person again. Especially, I know everybody's different at where they're coming from all over the world, but with cases we're seeing those go back up, telehealth will probably be around for a little bit. So if you are in that boat that you're going to be using it, just make sure to treat it as if it was an in-person visit. Make a list and everything like you normally would.
That's such a good point. And really, anytime you have an opportunity to talk to your healthcare provider and there's an issue, you should bring it up, because things can change. So keeping them up to date on what's going on is really important, and it really impacts your quality of life if you're addressing an issue. We had a question from Jessie. She wanted to know, do you recommend that people send, tools like I just went through in advance to the movement disorder specialist or the APP? I would say both.
Great question. Yes. And someone brought up the portal earlier, which I know we're going to get into, but one of my favorite things is when people send things like this or their questions ahead of time, because then let's say it's something that you've had before, I can go back and see, okay, we've tried this medication, we've tried this, I can kind of prepare for it just like y'all do, ahead of time if you send me those questions. So by all means, if you've got a good list, send it ahead of time.
Fantastic. The other thing that I'll mention about portals is that, they do often have that email system in there. And I know this is a difficult thing to broach, but sometimes there are issues that a family member, a care partner, even adult child, or somebody might want to bring up with a physician independently. Not that they're going around the person with Parkinson's, but because there are things that can cause some stress in a relationship, but still needs to be addressed. Those portals can be helpful because then it's just a way to communicate. This is a concern. can we address this in the next next appointment? And have you found that to be the case in your practice?
Yes. Yeah, there may be things that are sensitive, or they're being cautious and they don't want to upset the person with Parkinson's if they're noticing maybe they're more.
Oh, you're frozen. We'll give you a second. Well, this did not happen in our run through. We'll give her a second.
Oh.
There you go.
Sorry, I lost y'all for a second.
Yes, you did. So we missed everything you said. Do you want to try to repeat?
I can. So I was just saying, yes, it's helpful to bring it up to me ahead of time, because it may be something that's sensitive that they're worried the person with Parkinson's may get upset if they bring it up in the appointment. But if it's brought up to me ahead of time, I can make sure to keep an eye out for it, or just to mention it.
Right. So there are so many different kinds of things that can be potential problems that are part of Parkinson's. I mean, we just went through that very long laundry list of things that people might be unaware of related to that disease. So can you talk about, in your experience, what are some things that you wish people came in more prepared to share information on? Symptoms, issues related to certain symptoms. And I'm thinking, like, I recall several instances in my previous work with people with Parkinson's and their care partners that they didn't realize that the fuzziness they were experiencing, the dizziness, was actually neurogenic orthostatic hypotension. And they weren't bringing it up to the doctor because they were attributing it to something else. And so here they were dealing with a symptom that wasn't being fully addressed, and it wasn't the doctor or whomever, the healthcare provider, wasn't knowing it was an issue to even bring up with so many. That's just one example that I'm thinking of. Could you share some of those things that are really important?
Mm-hmm. I think a lot of people, when they think of Parkinson's, they think of tremor or trouble with walking, but it's so much more than that. And there have been studies that show that the non-motor pieces of Parkinson's can be more bothersome than the motor pieces. So I think that it's a lot of the time it's the non-motor things that people have a tougher time bringing up to us. The blood pressure, neurogenic orthostatic hypotension, you brought it up. That's just a fancy term, basically, that your blood pressure drops when you stand up. This is a big one that a lot of people don't realize can be related to Parkinson's or their medications. So this is symptoms like dizziness, sleepiness, weakness in your legs. It can look a variety of different ways. And often we will have people track what's called orthostatic blood pressures, checking your blood pressures in a couple of different positions. And we see this all the time, but most often people will talk to their primary care or to their cardiologist. And this is not necessarily something that we will often have people come to us about. But the medical community as a whole, it's not well understood that it can be related to Parkinson's. So it's important to bring those things up, or if you're seeing a cardiologist and talking about your blood pressure, make sure they know that you have Parkinson's too. Any questions about the blood pressure? I can.
Well, and I've heard people say, well, I could possibly have lower blood pressure because I have high blood pressure and I'm on medications to treat high blood pressure. Can you speak to that?
Yes. So it can be high, but here's the thing, it can be tricky. If you're only checking it when you're sitting down, that only tells you half the story. You've got to check it lying down and then sitting and then standing with a couple minutes in between. The reason being, it can just as easily as it can drop when you stand up, it can also go too high when you lie down. All that blood pooling in your brain is not automatically distributing the blood as easily as it should automatically. So you need to get kind of the whole overarching picture. Often cardiology and primary care only check your blood pressure when you're sitting down. Not always, but they typically will. And then they may add on a blood pressure medication, like you said, but that could be lowering your baseline blood pressure so that when you stand up, it can drop easier and you'll be more symptomatic. I see a question about steroids, methylprednisolone. Steroids don't directly interact with things like carbidopa, levodopa, but sometimes they can make tremor worse. They can affect your symptoms in some different ways, but it's not that they can't be taken together with Parkinson's medications.
And I know we're getting a question about, other than charting the blood pressures, wearing support stockings, what are some other tools and techniques that people can maybe use that they haven't thought of to manage?
Yeah, some great questions. So there's several things you can do other than adjusting medications. The support hose is one of them. Another big one is staying very well hydrated, drinking plenty of water. That helps keep that blood pressure from dropping. If you are not a fan of wearing support hose, as many are not, they're tough to get on, you can also do an abdominal binder. So picture like those Velcro ones that people wear after they've had back surgeries. Those can help with your blood pressure as well. And the other thing is salt intake. So this is one that you would want to check with your cardiologist, or if you have kidney problems, but increasing your salt intake can also keep your blood pressure from dropping.
Fantastic. That's really helpful. And I'm sure that NOH is only one of many different things that you see that people don't necessarily offer information on, but can be problematic. Is there any other like examples that you can think of that might be helpful for our audience today?
Yes. I know we could have talks on each of these things individually.
Oh, exactly.
I probably have two other big ones. The first one is cognitive changes, memory and processing, thinking. That's a big one. And that I would say is probably the biggest one, where I'm talking with a patient and their care partner. The patient may say, no, my memory is fine. And I can see their spouse next to them shaking their head. So there tends to be some disagreement with this. And that's where I think it's helpful to discuss these things ahead of time. You know, you don't want there to be any surprises when you're sitting there talking to me that your care partner has seen cognitive changes. So it's a good one to discuss ahead of time. And we can do, if you bring it up, I know it can be a sensitive topic, but there are medications. We can do thorough cognitive testing. If the concern is driving, we can do a driving evaluation. All kinds of things we can do for that.
And I had, so I have this, I'm sure I'm not the one that coined this term. I've heard it said in other situations and places, but I've had care partners explain to me what they call phenomena, that their loved one, when they go to see their healthcare provider, all of a sudden they walk straighter, they stand up straighter, they walk faster, they, minimize if there's anything going on. I'm not saying this is everyone, but, they act much better than what the care partner might be seeing at home. We call that showtime, or at least that's what I always called it. And then once they get back into the car, they sort of collapse because they use a lot of energy to put on that show, and it's maybe even a subconscious thing that we want to present our best selves when we're out there. But have you come across this? And
absolutely.
What would you say to people about this?
Yes, so we see it all the time. We'll have you walk in the hallway and your care partner is like, oh my goodness, you haven't walked like that in some time at home. So we definitely do see that, but we really try to get past that. We understand that. And a lot of Parkinson's is also by the history. So we're listening to you too. If you're saying that you're having a lot of freezing of gait, you're having a lot of tremor, we recognize that we're only seeing you for 30 minutes to an hour. So we know that this is only a part of the day. We also, on the other hand, will have people come in that they're tremoring more, or maybe they're more dyskinetic, they're more wiggly when they're here for their visits. Just like your blood pressure can go up, white coat hypertension, you can also have tremor or dyskinesia come out when you're anxious. So we can see kind of both sides of the coin.
Awesome. Well, I'm glad that we had that discussion, because I've heard that, and so I love that you were able to give both sides of that picture. And I know we've talked already about NOH, but we still have had a few questions about blood pressure. And one person made a really good point about sometimes those automatic blood pressure machines do run high. I know they do for me. Look like I have high blood pressure, and they take it with a manual one and it's normal. Any thoughts about that? And then somebody wanted to know, is it always related to position, and can it be caused by autonomic nervous system dysfunction? And I think that would be a good segue to some other things that you see, but I'm going to let you talk to that first part of the question.
Yes. To answer the autonomic dysfunction part, that's important. When we're talking neurogenic orthostatic hypotension, that is autonomic dysfunction, or dysautonomia is another name for that. That's the part of your brain that should do things automatically. There is dysfunction there. Your blood pressure should automatically adjust when you stand up. That heart rate should go up and pump that blood back up to your brain. If it's not doing that automatically, that's where we have the problem. So yes, you're spot on. It's related to the autonomic nervous system. Typically, when we are talking about Parkinson's blood pressure issue, it is almost always related to position. Sometimes people will have it also when they sit down, like they go from lying down to sitting, and even the blood pressure can drop in that position. So it's not always when you're standing. It can also just be when you're going from lying down to sitting, or even if you're up and walking around for a while, that's when it can come about. Let's see, the other one was the manual machines. So yes, that can be a problem. The issue here though is, let's say it's only you at home and you're living by yourself, you may not have another option. So one, you can take your blood pressure machine into any provider and have them use your blood pressure machine and then use theirs to see how accurate it is. The other thing is we are looking mainly at the change in position, the blood pressure change in position here. So even if it's not 100% accurate, generally, if it's off a little bit, you can still tell if there's a difference by change in position. That's the main thing we're looking at with Parkinson's, at least.
Fantastic. Now, I want to switch gears a little bit, and I want to talk about one of the things that I'm sure that you've come across, and we have so many different medications available now to treat Parkinson's related symptoms, and some of them are still pretty new. So there's always the issue or the aspect of getting authorization for those. And I wondered if you could speak to that, because I think that's something you probably have some experience with, and you can share, like, from your end, what actually goes into making these things happen.
This is such a good question, because we are very blessed to have a lot of good treatment options with Parkinson's. New things coming out all the time. A lot of the new medications, as y'all know, they can be expensive. However, on our end, a lot of them, they do have ways to get it affordably. It takes some work on our end though. So when we recommend a brand name drug, you will typically sign a form that gives us consent to work on a prior authorization or to discuss grant money on your behalf to get it affordably. When we do a prior authorization, that basically is just working with your insurance to get that drug approved. Those can take, it depends on the drug, but they can take up to 2 or 3 hours for one patient, one prior authorization. A lot of time on our end. So what we run into sometimes is when we start doing that authorization on our end, a patient may come back 3 or 4 months later, and they may say, well, I read the side effects and decided not to take it. And that's heartbreaking for us because we know how much work has gone into it to get it approved and covered on our end. Whereas if you just read the side effect list, there may be some questions we could have answered to make you more at ease with that medication. So if there's any medications that are new that you're unsure about, always ask your provider. And recognize that a lot of work typically goes into getting those medications sent to you and affordable for you, not just your provider, but the specialty pharmacies and your insurance companies too.
Mm-hmm. There's a lot of paperwork related to that. There's a lot of paperwork related to any kind of healthcare. I know just even managing all the different bills that come in from different appointments and different providers and labs and all of that can be overwhelming. And that's why having a good personal health record can be really helpful, because you might need to go back and reference things. You want to check dates on bills. I know I personally have been fighting on a bill to be covered, all surrounding coding that was done. And the way it was coded, the insurance didn't like it and they denied it, and it was back and forth and back and forth. And it's exhausting. And if you don't take good notes and if you don't track those things, you end up paying more money than you have to. And, you know, that's a huge expense for everybody because you've already paid so much for the insurance and the premiums and the co-payments and all that to begin with. So one of the things I want to just touch on is the handout that we sent you, which was about creating a personal health record. And there's actually some different types out there that we've referenced a little bit. One would be the patient portals that a lot of healthcare providers now have, that is tied to their healthcare system. And there's some acronyms that get confusing. So Meredith, you know, feel free to interject any of these. One would be the portal, which is, you know, you get an access to get into their portal, and in there you can, you know, look at your summary from your doctor's appointments. If there's been lab work or other tests drawn, you can see where those are. You can look at those. You can ask questions. You can download things from there. That is one type of thing. And that is tied to the electronic health record, which is what on the practitioner side, that's what they're inputting a lot of information on. And sometimes people think that's what their personal health record is, but the problem that we run into, and I'm sure that you have, Meredith, with some of your patients, is that, you know, and all the practitioners that you might see, they may not all be tied to that same system. So the psychiatrist that you saw is in a different system. And so they can't, your movement disorder specialist can't see what was written or anything that was ordered from that physician's practice. Could be the same with your primary care, your other specialists. So having your own personal health record that's not tethered to that portal can be helpful, in addition to using the portal. So the handout that we gave you just describes the differences between those, why you should, you know, understand that, but then different ways to develop your own personal health record, which can be a variety of different things. It could be, you know, using an app on your phone, and we gave you a few options. These are not exhaustive, so just know that that didn't, you know, list everything, but that's one way of doing it. There's websites that you can use, and then there's the type that you develop in a literal hard copy 3-ring binder. And I just wanted to take a second to share my screen again, because this is just a couple of examples of what that might look like. So I'm going to share that, and actually let me just enlarge it a little bit if it'll let me. All right, you seeing that okay?
Mm-hmm.
Okay. So some of this stuff you can put together on your own. This one was on Amazon. This is just a folder, and you can just see it has different types of tabs, his pockets, so that you can categorize your sections. And in your handout, it gives you some suggestions of ways to break this down that you might include. But you can do this however it works for you. Everybody has their own organizational system. And then this one was another that you can just order, and it actually has all of the guts that go into the booklet, including little protectors. And then really, anytime that you go to the doctor, any of them, you should have at your fingertips all of those key things. And you don't have to lug this whole thing, but like the key things that you would need for that appointment at your fingertips. So if they ask you a question, when was that surgery you had for your hernia? Oh, I don't remember. Or what date did the doctor add this medication when you were at the cardiologist? I don't know. So this gives you an opportunity. You have it now documented for you to go back and have that at your fingertips. So I just wanted to bring that up because quite honestly, it's a challenge managing this. And I would love to hear how you have benefited from people having organization when you've been working with them.
Yes, it's very helpful. And I know it can feel overwhelming thinking, oh my goodness, I see so many different specialists. How can I have all of their notes printed out? It doesn't necessarily have to be every single note that you see someone printed out, but even just tracking medication changes, major events like hospitalizations or surgeries, those are the big ones. And taking notes at each of your visits so that you can remember, oh, my cardiologist did say I need to make this medication change. But it's tough for us when we don't have communication between offices necessarily to know everything that's going on. You can ask, typically with the new systems being electronic, you can have people fax one another their notes. So every time we have people come in, we make sure to have their primary care provider in our system, their cardiologist, their psychiatrist, whoever it is they see. And then automatically those other providers will get our notes every single time you see us. So I think that's really a helpful tool to have these days. Just make sure that everyone knows of each other so they can communicate.
Absolutely. And that list we gave you was kind of just those key things, because if, like Meredith was saying, if they're going to send that information to all of the providers you're seeing, then you need to provide them all of that information. So you need to be prepared to tell them who all your doctors are and maybe give them that office contact to save them a step, who your emergency contacts are. Like who outside of maybe your immediate care partner, if you have one that's with you, who else would you contact? Do you have a healthcare surrogate? Do you have those documents? And, don't forget to include things like your eye doctors also, your dentists. Those are still, providers that may need to know that information, things like your insurance information, stuff like that. Now, it's not just for seeing the physician or the nurse practitioner when you go into your appointments. Let's talk a little bit, Meredith, about hospitalizations. Because that's a whole nother ball of wax. Yes. So there's challenges just, going into the hospital and making sure that we get our medications on time, that we're not substituting medications because they don't have all of the newer stuff on their formulary. Sometimes you don't even know that people are in the hospital. Can you just give some perspective on hospitalization?
Yes, and you're exactly right. Unfortunately, a good chunk of the time, we are not notified of hospitalizations. Sometimes we are, but unfortunately, we are not a lot of the time. So if you go to the hospital, first of all, be sure that the providers there are aware of your primary care provider, your neurologist, and they can send us the report if they know. If it's related to your Parkinson's, we should know about it. So make sure that either the providers there contact us, or that maybe your care partner or someone in your family lets us know. We will often talk to the hospitalists about your care if medication changes are needed, but we have to know about it first. So that's key. The other thing is, we already talked about, a lot of Parkinson's medications are specialty medications that often are not on hospital formularies, meaning they won't be able to give them to you. So a good example of that is Rytari or Nuplazid or Northera, a bunch of these medications that y'all might be familiar with. If you go to the hospital, they may not be able to give those to you. So be sure to just bring all your medications when in doubt.
Right. And so we do have the Aware and Care kits that many of you probably have or have heard of that Parkinson's Foundation offers. And those are helpful in terms of being able to communicate some of those things. But Meredith, is there any thoughts that you have in terms of besides the Aware and Care kit, what people can do to help maximize their stay, and maybe some things that they should be aware of to keep an eye out for when they're hospitalized? And I'm thinking of, like, you know, maybe they're on pain medication, in addition to the fact that they may not be getting their normal medication schedule that might make them groggy. Maybe they didn't have confusion and stuff before, but then they become a little confused in the hospital. They're not eating the same, they're not moving as much as they were. So is there any thoughts that you have about that you could share?
A lot of the time when you get into the hospital, your medications may not be given exactly on time like you do at home. They're of course, they're busy, but you do kind of have to be aware that your medications still need to be on time, even when you're in the hospital. So have an advocate, if you can, there to push for that. It is also very common, you touched on this too, that while you're in the hospital, just a change in environment, your medications being off a little bit, if you have an infection, like a bladder infection or pneumonia, that can affect your Parkinson's or hallucinations, your memory and thinking. It's common for those things to be affected during that stay at the hospital.
Definitely. All right. And I see Kelly did put the link. If you have not already obtained an Aware and Care kit, you can order those from Parkinson Foundation. They'll mail them directly to you. We have had a couple of questions, and they may not be exactly related to hospitalization, but I want to go back and make sure we answer those. So Jesse asked, what is the best way to handle a request for a billing code change if payment for a particular code is denied? How do you know even when and how to ask the insurer to use a more effective and different billing code? And Meredith, you might have some insight in that. I'll just share what I just went through. The process I went through was that I got a bill and I called the insurance because it said that it was, it wasn't covered. It was patient responsibility. So I called the insurance to ask them, why is this all my responsibility? It was not an atypical thing to have lab work to have done. And they told me that the coding was incorrect. And so I called the doctor's office and asked them to recode it in what they told me. And it ended up having to go back and forth and back and forth. The insurance actually called the doctor's office and asked for a recoding, and then ended up going into an appeal process, which actually the insurance person that I was working with helped me with, that ultimately ended up being denied. Yeah. They just didn't like the way it was coded, even after a coding change. So there are times where you may lose the battle, but it's worth the fight, just because I would have had, I'm going to have to pay $200, but if I hadn't at least fought to try to not pay that $200, I would have been happy to fight it and win. In my case, I didn't. So I don't know if you have some things to say about that.
Yeah. So with lab work or with imaging, we often on our end will not see what the insurance needs for it to be coded. we may put it under a certain diagnosis, and then it turns out the insurance does not like it under that diagnosis. So a good example of that, maybe we're working up neuropathy, numbness or tingling in your feet, and we're wanting to see your thyroid or your glucose levels. Well, the insurance may want the glucose levels to be coded under diabetes check or, you know, a different diagnosis. Whereas for us, we're checking for neuropathy, but that may not be a covered code. So in terms of labs or imaging, often we will get a call from the lab, but if you get a bill that you know is not correct, either contact the lab or contact us. And oftentimes we can go back and change the way we coded the lab to get it sent correctly. In terms of medication, this generally, if we are getting a medication that the prior authorization has been denied, we will get notification about that, and we can do an appeal or we can send it in a different way. There are often things we can do to help with it. So bottom line, if it's not getting taken care of, make sure that your doctor knows about it. And I think there was also a good question about lab work earlier on about, do we recommend regular blood work? There's not, to be honest, there's not a lot of lab work done with Parkinson's. We can't diagnose it with lab work. There's not necessarily a way to track your dopamine levels in blood. So there's not necessarily labs that we routinely check. The only ones that we'll do sometimes would be maybe B6 or B12 levels if we're seeing some fatigue, or sometimes we will order labs for neuropathy. But most lab work will be with your primary care, your other providers for the most part.
Awesome. We also had a question earlier in regards to, should I continue my Parkinson's medication even if nauseated and vomiting?
Mm-hmm. So always call is the bottom line there, because if your provider doesn't know you're having that problem, they can't help you with it. So definitely call them. If you are having nausea and vomiting to the point that it's happening with every single dose and you can't take it, you want to call them right away. And typically they'll call you back, and of course they'll change the medication, or they may have you stop it. We're not going to ask you to take a medication that you can't tolerate. We'll change it.
Okay, and I'm going to go back to some questions that we had in regards to hospitalization. Mm-hmm. So Denise wrote in, so frequently delirium sets in with med changes and additional hospital meds. Doctor advised it be temporary, and it was, thank goodness. So that's good to know. Can you speak a little bit about delirium?
Yes, delirium, I was kind of describing it earlier, but essentially it's often temporary. It's when you're in the hospital. Maybe you just went through a surgery and you had some anesthesia. You can go into delirium for a little bit after that. Sometimes it is just as simple as a change in environment. And at the hospital, your days and nights get switched a little bit, or your medications get off. Delirium is temporary. It often gets better. The amount of time that we see improvement can vary. Sometimes it's a couple of days. I've had some people that it's a couple of weeks to months. It totally depends on the person, but often hospital or after a surgery, those things are temporary.
Great. And Jean made a comment that her husband had a psychotic meltdown because they couldn't fill his clozapine prescription due to restrictions, mm-hmm. and she wasn't informed. I had to go spend the night in bed with him to keep him calm for the last 3 nights. So that's a significant issue, and just some of those little things that can, not little, mm-hmm. but some of those kind of situations that occur mm-hmm. in the hospital.
So I think clozapine is probably a special circumstance because it does require regular blood work to be able to prescribe the medication. And that is not something we can bypass. It's by law. We have to have regular blood cell counts to make sure the white blood cells are not dropping for you to continue taking the medication. A lot of the time they do check that blood cell count in the hospital. So always ask why couldn't it be filled? If they just needed a lab done, then they can fax that lab over to your provider to put that lab in so that the pharmacy can fill it. So I think that's a little bit of a special circumstance. Not everyone will be on clozapine necessarily.
Right. So we've covered quite a bit, Meredith. I don't know if there were some topics that you wanted to bring up that we didn't get to that we should probably share with our audience with this topic today.
Yes, we could go on and on about all the different symptoms that we see, but I think a good one to mention is just every Parkinson's patient is different. So be careful comparing yourself to other people. Know that your story is your independent story for Parkinson's. When we are treating you, your medications, your story is completely specific to you. The amount of dopamine you need is going to be different than the person that is next door. I think that's just an important thing to remember. And that's why there are movement disorder specialists. It's not always just general neurologists that treat this, because it is an art and it's specific to you. I think that's a good thing to remember too.
Great. And so I think we still have a little bit of time. If there's any last questions, if anyone wants to unmute themselves and ask a question, just, notify us, use your reactions to raise your hand, let us know. Bruce wrote, my husband is now on chemo. It seems to be exacerbating many of his PD symptoms. Is this something you've seen?
It's a good question. I think there was a question earlier about chemo meds.
I think it was the same person and we just didn't get to it. So thank you for bringing it back up, Carol.
Yes. So it depends on probably the medication specifically and what type of cancer. But in general, chemotherapy medications don't directly interfere with things like carbidopa, levodopa. They're okay to take together. But when you're going through chemotherapy and radiation, it is very tough on your body. Your body is stressed. You may not be sleeping as well. Those things can, of course, affect your Parkinson's. I have a patient in particular that is on chemotherapy for his cancer and has very chronic fatigue. And for the longest time, we tried to troubleshoot, is this because his carbidopa, levodopa was wearing off, or his Parkinson's medications weren't working as well? Or was it related to the chemotherapy? So it can be difficult to tell. And sometimes it depends on the timing of symptoms when it's happening. So that may be one to talk specifically with your provider. There was another good question earlier that I also wanted to address about if you're moving and how to transfer your documents. So this does happen a lot. That's where it's important to be organized and to have everything that you need. But if you know where you're moving to, always talk with your neurologist about, do you have someone you know in that area? Is there a movement disorder specialist in that area? There is a movement disorder specialist directory. I think it's on the Movement Disorder Society page, but
yes, and we actually have that link directly from our website. So yes.
Perfect. Yeah. So if you have one picked out, you can always have us fax everything they need so that they have your records ahead of time and can go through that. That's important.
Absolutely. All right. So this is an interesting, it's a really good question, actually, because we've been talking about the responsibility of the care partner, the person with Parkinson's, to be armed with information to provide, obviously, to the treating provider. They want to know, what is the provider's responsibility for the total treatment plan for all of the PD symptoms? So from your perspective.
Yeah, it's a good question. Generally, anything related to your Parkinson's, your movement disorder specialist will treat. So that could be a variety of different things. That could be constipation, that could be your mood, that could be sleep, that could be urinary urgency. We will help manage a lot of those different things. Now, a lot of those things, like specifically, let's say urinary urgency, if we try a couple of different things and we're not seeing the results we want to see, then we will team up with urology to get better control of what we want. Or another good example is psychiatry. we will treat initially maybe some depression or anxiety. We'll treat that if it's related to your Parkinson's. But there are some cases where, okay, it's getting worse to where we're not seeing the results we want to see. Let's co-team with a psychiatrist to get better control. So I think a lot of people want it to just be one person that manages everything, but it's not always that simple. Sometimes if we are not seeing the results we want to see, we'll work with someone that's their specialty and they can help us more than maybe we can with the basics.
Absolutely. It is a team approach, and that is the MDS, that is the APP, that is you as the person with the care partner. And like Roger said, the OT, the PTs, those are nerd trained. They're all a team. Yes, David, yay for teamwork. It really is a team in order to manage this disease. So
yes, and if you're, I will say too, if you're not necessarily getting the answers that you want, like let's say you bring up something to if you're seeing a general neurologist or even your movement disorder specialist, if you are not getting the answer that you are wanting, maybe they're not comfortable moving forward with deep brain stimulation, or they're not as familiar with something like Duopa, it's okay to get a second opinion and to ask other people. That's okay. We are not offended by that. You know, if you're not getting what you need out of your care, get a second opinion or talk with a support group about what you think can be done.
And I think we had 2 more questions. So I only have a couple minutes, but maybe we can squeeze in some quick answers for these because I think they were good. And one of them was about COVID vaccines and COVID with persons with Parkinson's. And I know you probably have had this experience. So
all day, every day lately.
Yeah.
So this is just a general answer, but the vaccines are safe with people with Parkinson's. So we are recommending patients to get them. Of course, there's individual people that they may not be safe, but in general, get those vaccines. They're saving lives. They're reducing hospitalizations. They can be very important.
Thank you. And then one last question before we close today. It was about dyskinesia. And I know that it's sometimes a confusing thing. This person's saying that their dyskinesia seems to increase when the medications wear off, become more intense. So I know that this is, the off and the dyskinesia is a huge balancing act. Can you just spend a minute or so speaking to that? Yes,
and we could probably have a whole thing on off fluctuations. So yes, dyskinesia typically, think of Michael J. Fox, that's those big wiggle movements. Typically, that is from too much dopamine in your system. So most often it's at the peak of a dose when you took it maybe an hour or 2 earlier. More rarely, and it sounds like, Jenny, this may be the case for you, more rarely it can happen as your medication wears off. Dyskinesia can. In those cases, you probably will need to touch base and discuss the timing of your doses. Maybe you can add in a different medication specifically for dyskinesia. Think about deep brain stimulation. There's a variety of different things that can be done. But if you're not sure about when you're having wearing off, when you're having dyskinesia in relation to your doses, sometimes we will have people keep a motor symptom diary, literally keep track, write down when your symptoms are happening and bring that in so that we can see those fluctuations. And thank you, David. That's so sweet.
Well, this has been fantastic, Meredith. You've given us such great insights from the provider's perspective and being able to partner in dealing with all the different symptoms that can occur and managing all of the information that needs to be managed in order to provide you that detailed information. So I thank you so much for your expertise today.
Thank you.
I thank you, and hope that everybody today feels like, even if they felt that they were very prepared for their medical appointment, that maybe there was some tidbits today that Meredith shared that will help you be even more so. Be prepared for your physician appointments or even coming up with and developing your own personal health record. Meredith, any last words of wisdom?
No, thank you so much. This is great. I love doing these. Let's fight Parkinson's, keep track of your symptoms, make lists, and we're here on your team, on your side.
Awesome. Thank you so much for joining us, Meredith. Thank you everyone for joining us for this 4-session series on the art and practice of planning. I hope this will help you with your planning and healthcare management. If you would all be willing to give Meredith the wave of gratitude for her time and expertise today. Keep your eye out for the email. We will have the documents attached to that. You all have a great rest of your Wednesday. Thank you.
Thanks, everyone.
Bye.